So to sort of take us to the next level and talk more about sort of state of Michigan's agenda, it's my pleasure to introduce to you all Nick Lyon. I've had the privilege of knowing Nick for a couple of years now. You can see for all of our speakers, their bios are in the Connecting Michigan brochure. Nick has a pretty distinguished bio. He's a Yale grad. When it comes to state government and health policy kinds of things, even budget stuff, he seems to know it all, and experienced a great deal of it. You may not know this, but Nick, I think, in addition to his sort of easygoing way to tackle and resolve hard programs, he's got a real nice smile, so you don't see it coming when he digs right in and solves something. He has a sort of good acumen for health policy kinds of things. But I think, and I have some evidence, that his true sort of rise in this whole industry, because he's the director of the Department of Health and Human Services, which I think is almost 45% of the whole state government, is actually all, and that's just a theory, because of his passion and knowledge and involvement with health information technology and health information exchange. Now, you may wonder why I have evidence of that. Well, you can just sort of plot it. First, he was sort of on the HIT commission, and he was deputy director, and then he was appointed to the MiHIN board, and almost overnight, he became the director of the department. And then, a little while later, he came to his first board meeting where we talked all about the depth of all this, and almost immediately, the next thing we knew, he was the director of 2 departments all put together. So all I'm saying is that not only is Nick sort of very talented and in charge of a great deal of what we care about, this health information technology stuff is incredibly transformative, and Nick is exactly evidence of that. With that, I'll turn things over to Nick Lyon.
Thank you, Tim. Tim's exactly right. It was one MiHIN board meeting, and before I knew it, I had 14,000 employees and a $24 billion budget, so it was quite the springboard. Actually, it's sort of interesting to note. I'm probably one of very few individuals who serve as a director of the State Department who actually started as an entry-level analyst within the state. And not many people know this because I grew up through the finance and budget world. But my first job at the Attorney General's office was actually working for a department manager who would be the equivalent of an IT systems manager today. And as Tim was talking, I was thinking about how far information technology has come since then. It was the late 1980s or early 1990s, and one of my first projects was taking a multi-part carbon travel voucher that if you worked for state government in the 80s, you know exactly what I'm talking about. And they made this basically something that you could type on a single sheet of paper and photocopy it, and that was the first big improvement in it. And we had a database, I wish I could remember, CPT was the name of the company, and they were down on South Lansing, and they had developed basically a dumb terminal that the secretaries could use to type briefs and things of that nature. It was as advanced could be. I mean, we were minutes away from the mag card typewriters, which fortunately I can't envision in my head anymore. And the top screen of these things were actually linked. They were linked to a server in a database, and this was very new. And of course, the first things we sort of did was personnel, and we developed a case management system for the attorneys. And being new, they said, hey, what do you think you want to do? And I'd gotten into it and learned everything as I've seemed to learn by fire, just getting in and digging around in the stuff. Started helping people with database reports. If there was problems that somebody had, it's like I could get in there and redesign them and do a new one. And I thought it'd be pretty cool if we did a travel voucher. So the first thing that happened is they said, well, how are you going to make it duplicate this on the form. How are you going to put it in the fields? And I was like, no, that's not what we're going to do. We're going to create the fields and populate them and make it so that actually, it prints the form on a sheet of paper. And I can remember the resistance of the legal secretaries going, what are you doing? We know how to do this way. And we implemented it, and just like anything else, but at an extremely small scale. We had about 2 days of pain, right? Fields didn't work right. The account codings that was pulling up, because it was a database, we were linking to other things, so they could put in their account code, and it would put the title in, and that wasn't right. And it took a few days, and it worked. And then about 4 weeks later, I was like, that's absolutely incredible. I can't believe you did it. I'm like, seriously, it was 2 days of some programming and really coming at it from the perspective of the people who were using the program. And that will come into play a little bit as I talk, but I thought it was just a very interesting link. So the governor talked a little bit about Healthy Michigan Plan. As I have a tendency to do, I've pulled my bullet points apart and put them back together in the order I want to talk about them. But we're going to start with Healthy Michigan Plan and just sort of work backwards to the reorganization, and it's easiest for me to explain it that way. The Healthy Michigan Plan went up April 1st, 2014. I don't know if we have given enough credit to this governor or this legislature for taking the chance and doing it. It was the Medicaid expansion that, as you're aware, in many states, they chose not to do this. $3 billion comes into our state to provide services for individuals who just 14 months ago did not have any sort of way to access affordable health care insurance. So this has been a huge success. As of yesterday, we were at 577,000 people, 577,277, and you can check all those digits. We've peaked at 605,000. What's made Healthy Michigan unique is, it started as an expansion, just like the Medicaid program, but as we moved through the legislature, we realized we wanted to do more with it. We started trying to figure out how could we build in personal responsibilities or incentives for healthy behaviors, and we were quite successful in building a program that really addresses some of those features, and sometimes with much skepticism. The business case, and we had to make a business case for Healthy Michigan. The business case was that by providing people with better access, using federal funds, which we did, to replace general funds, so using federal dollars in place of our state taxes that we use in behavioral health, especially, and in corrections to some extent. So there was a cost benefit, there was a benefit there of replacing the general fund with federal funds. But by providing better access, we'd be able to improve the efficiency of the system, and eventually working backwards, we'd be able to improve the health of those individuals. A little tangent, the governor, one of us first, he does these messages, and we certainly didn't recognize how important they were in the first, before the first couple came out. But when he feels strongly about something, he'll do a policy message. And one of the first ones he did was the health and wellness message that emphasized the 4x4 plan, which is all about encouraging healthy behaviors, moving around more, making sure you're seeing a primary care physician. But if you know the governor, it was all about metrics as well. Everything has a measurable. So what's your BMI? I don't disclose mine. What's your cholesterol? I also don't disclose mine. Blood pressure, etc. But certainly, this has been a very key focal point for him. And as we've moved everything forward, he still comes back to those original tenets that he had about what can we do with the system to improve people's health and to make healthcare more efficient. So personal responsibility is a big part of it. As you can imagine, the incentives are built into the program. Some of the skepticism that we found is we really, the purpose of the incentives are that people could get back some of their cost sharing. I kind of skipped over that, but there's cost sharing that's involved with it. So if people choose to improve their health in some sort of way, then the cost sharing that's required of them to participate in the program, they can earn that back. And we put in different requirements, and there was some skepticism by the legislature about whether or not this would really succeed. Some of the activities we chose were easier to do than others. And what we found was that there was not a path of least resistance to this population. They were not coming in and choosing the easiest thing. What we found is a vast majority picked more than one factor. that they wanted to improve. And of that, most of them picked giving up smoking or improving their own fitness. And as you work backwards and think about those goals and what really drives healthcare costs, both in the state and nationally, you see where that can actually help us make significant progress moving forward. So that's the first step of Healthy Michigan, was ensuring that people had access. And I think now where we are with that is now we're trying to really move forward and encourage better utilization. And what I say is we now need to teach people how to use a healthcare insurance card. And this is not unique to the Medicaid population. We certainly have many of us, and I can give you an example from my own life, where we have a tendency to rely upon the emergency room more so than other more efficient and less costly providers. And the example that I used from my own personal history was when my son was not yet 1 year old. He spiked a fever, and we couldn't get the fever to go down. And that's one of those scary things as a parent. You have a kid for the first time. I don't remember 103.5 being a normal fever growing up. So you call the primary care physician and they say, giving him Tylenol? Yep, go to the emergency room. So we walk into the emergency room, and what I haven't pointed out in the story, which will come into play, is that my son did not gain weight the way he should until he was probably 4 or 5 months old. So we give him the Tylenol and the Advil, and gone in and gone to the emergency room, and the nurse asks us, okay, what did you give him? And she goes, okay. And how much? And we, sure. She goes, okay. And she walks away and comes back and gives him more medicine. She turns to us and says, see this table on the back? When they get to be 9 months old, you have to give them more. And that was seriously, it was my sort of, unnecessary ER visit, that if somebody along the way could have said, hey, check that back of the bottle. So that's the type of thing that with better information and better communication, we can all make a difference. So again, teaching people how to use the card, helping them get back to access the primary care physician rather than the ER rooms for medical care is going to be a very important component of everything we are trying to do moving forward. With increased primary care, I really fully expect that we'll see immediate benefits in the areas of improving both the treatment of chronic disease, especially around diabetes. If people are treating their diabetes in a way that is effective, certainly that's going to have an impact on emergency room visits and hospitalizations, and that's just one example. You work that one step back further. With better primary care, and if you integrate with population health ideas and public health departments and their goals, what can we do to help prevent diabetes going forward? That's just one example. What can we do to prevent heart disease, cardiovascular issues? So certainly the integration of all these systems becomes very, very important. And that really means that we have to have strong community partners, right? Not just the public partners. The local public health departments will be very important. Community mental health agencies will be very important. But we also have to have strong community leadership. In Flint, for example, they have the Greater Flint Area Health Council. This is just one example of business and leaders and community partners getting together to say, what are causing our issues here in our city, and what are health related, and what can we do to improve that? And that's the type of leadership that we need. We certainly can't do it from Lansing all alone, and we're not going to try to. We have to build the partnerships, and we have to have a strategy that makes sure that we all recognize that we win when this happens. So Tim referenced my meteoric rise due to my 3-hour visit to the MiHIN board. It's really pretty interesting because through that time frame, what we'd found, and there is a very serious aspect of my being here today in this position being a result of technology. When we were when the statute first passed for Healthy Michigan, we had a very limited amount of time to get the system up and running. And there was a strong desire to have a council, basically. They were feeding up to the directors to ensure that this group could be successful. And really, it happens this way sometimes. Out of some frustration of what had happened previously, I volunteered to serve in that role. So I ended up chairing a group that was basically responsible for reporting to the directors on the success of the plan. Many of you, a few of you in this room were on that group, and I appreciate your participation because I helped drive it, but I certainly wasn't one of the people that were up until 4 o'clock in the morning trying to make sure everything was working correctly and doing all the testing. At the end of the day, that was a hugely successful launch. Obviously, we'd learned from what happened at the Federal Health Exchange, but I can tell you today that we're exchanging information with the Federal Exchange as well in a successful way. So many of the goals that were established from an information exchange standpoint have been accomplished, and that says a lot for the work that many of you do. So with that in mind, and with my predecessor, Jim Haveman, retiring, and knowing that Director Corrigan of Human Services was going to retire as well, they began talking to me about helping out. I was the people group lead. The governor organizes his departments into groups. People group consisted of education, civil rights, human services, and the Department of Community Health. And they had asked if I'd be willing to take on more of a role in trying to be more customer-centric in what we're trying to do from a state agency perspective. And the governor is very focused on the consumer and on the customer in everything we do. And I shared that vision with him. So as we moved through December, we started looking at the commonalities, especially among those that we served in human services, whether it was the Family Independence Program, which is cash assistance, whether it was FAP, the Food Assistance Program, or some of you may know it as SNAP, whether it's state emergency relief. As you can imagine, the interface between there and things like Medicaid, behavioral health services, people visiting the local public health department, mothers needing WIC to help their children attain healthy meals. There's a huge duplication of those individuals that are being served by both systems. So the governor and I had discussions about what can we do to better serve those persons, and that led to the reorganization, which he alluded to, and I was quite concerned he was actually going to announce in the State of the State standing there, and then he announced it, or at the inauguration, excuse me, on January 1st. He did announce it in January, and then we issued the reorg in late January, and on April 10th, so not even 2 months ago, we became an official state agency, the Department of Health and Human Services. I'm going to talk about sort of inside baseball. I think it's important to recognize a few things here. First and foremost, this wasn't going to immediately change everything at the local level overnight. There are 83 human services, local offices that exist that serve directly with individuals every single day, compared to what we had in community health, where we contract with agencies, right? We contract with Medicaid HMOs who contract with physicians. We contract with local health departments. We contract with behavioral health entities. So it's a little bit of a different culture and a little bit of a different process that are involved when you're directly serving the people and when you're really more involved with entities that are helping to serve people. Goals are the same, but the culture is a little bit different. So overnight, we went from a $18 billion community health department to a $24 billion health and human services agency. So 3/4 of the money was on the health side. We went from 3,000 employees to 14,000 employees. So 11,000 more employees. So you can see that the ratio of employees and the ratio of money was almost exactly the opposite between the two. So as we've pushed forward, our first goal was really to establish a leadership team, align our priorities and goals, and really control what we can control in the near term. The governor had the legislature had 60 days to review the executive order. They took those 60 days. I spent a lot of time over there trying to ensure that this was the right decision. We were successful there, and I've always felt that maybe my single biggest marker of success would be when we had this budget bill passed, and we went through with 2 different subcommittees, and both the House and the Senate, which was unique, and 2 very difficult departments from a budgetary perspective, and we were able to get almost all of our priorities addressed and we were able to actually get that budget moved through a legislature that I think at times was quite concerned about some of the things we were doing, both from a policy perspective, both from an organizational perspective. So a couple of people I need to give credit to, specifically my chief deputy, Tim Becker, who managed this internally masterfully. Farrah Hanley came over to the state budget office. She's now our operations director. And then our Medicaid director, Steve Fitton. Sue Moran is our public health director. Carrie Cederberg, who is our Office of Services of the Aging. One of the more controversial pieces we did was the Office of Services of the Aging was the Type 1 agency, which meant the director was appointed by the governor. And we actually consolidated that into the department, made it the same organizationally as like Medicaid and behavioral health, but gave it more responsibilities, specifically around adult protective services. Again, a way to say, if we're trying to align the individuals with the programs we do, then we need to bring the programs together in a way that can serve those people. The Children's Agency is something that I'm learning about every single day. Child welfare is a very difficult entity to manage. It's the ramifications of your actions and what you see each and every day. It's absolutely incredible, the people who take this on, both from public employment through the Department of Health and Human Services, as well as foster care families who you call at 3 o'clock in the morning and say, I have a child who needs a safe place to sleep tonight. Are you willing to take this child in? And they say yes. And it's been both enlightening and at times depressing, but most time very inspirational to see how people respond to others when they are in crisis. Approximately 6 years ago, the state of Michigan was sued. Basically, we were moving down a path where a federal judge was going to find that our child welfare system was violating the constitutional rights of children. Under the leadership of Director Corrigan, we have come a long ways. And right now, we are in the process of working with the federal judge, working with the plaintiffs to show what improvements we have made in our child welfare system. The agreement's going to live on for a while, and we still have our work to do. But certainly, we've come a long ways and are continuing to demonstrate it. So that's a very important step there. And then working back to our eligibility workers. There's our local offices all do eligibility in some sort of fashion, both Medicaid and the other programs. And the link here is with the Healthy Michigan Plan, much of it became automated, but anything that couldn't be automated, they had to walk in and see a worker. And then when that worker walks in the door, and this is the goal of the reorganization, what are we doing to make sure that that individual is receiving the services that they need? And aligning those services, reducing fragmentation, really ensuring that that we're seeing the whole person. These are all goals the governor talks about in all of his programs. He refers to it as the river of opportunity. Not many are aware of this. We are actually his second river reorganization, the first being what he did with talent and economic development, trying to get people prepared to get into the workforce. I feel that this is very important. I feel it's a very important initial step. What can I do to help people be prepared to take that step into the Talent and Economic Development Agency? As you can imagine, when people come in crisis, it's not their easiest day. They are applying for services. They're trying to figure out what's going on. They could be in a situation where, especially over the winter, a heating bill, they may be getting their heat shut off. They might not be able to pay a rent payment. They've lost their job. They didn't know what programs existed. So they come in the door. Customer service is very important, and what can we do to help them? And really, that fits back in, going back to the health side. We can talk all day long about improving people's health. We can talk all day long about eating healthier and moving around more. But if you don't have safe streets to walk on, if you don't have a grocery store that serves fresh fruit within 9 miles of your house, if you don't have an environment that really helps people make the right choice, then you're still going to have issues. So this is really about now coming back and looking at what the determinants of health are, what's in the environment where the person lives that's impacting their ability to be healthy. And that really, when you look at this reorganization, it's about coming all the way back and not looking at the symptoms, but looking at the root causes of what causes these issues and trying to help people address those. It's a difficult task. as you can imagine. There's local power both in the community mental health agencies and the public health departments, but we've seen a great spirit of cooperation. Even just this morning, Linda Zeller, who's our head of our Behavioral Health and Developmental Disabilities Administration, sent me an email really lauding the progress we've made in standardizing just the information fields around substance use disorders, so substance abuse and substance use and behavioral health. 1/3 of the people who receive services in behavioral health also have a substance abuse issue, co-occurring disorders. So it's just one step that shows where we can go. If you start standardizing and making these things easier to use, then you can really start laying the groundwork through technology. So the reorganization, we're done there. The budget should come out of the legislature today. So while that may be some inside baseball, it's a hugely significant accomplishment for those who really worked on this day to day. In the future, there's a couple of things that just going on that we're looking at that I want to touch upon. I got to look and see where I'm at time-wise. I told somebody I'd do that somewhere along the way. So a couple of things we're looking at in the future that are very instrumental in driving our vision forward. First, we just issued the Medicaid rebid. We have 13 Medicaid HMOs that provide services to those in Medicaid, 1.7 million recipients. This will be the largest bid in state history. It's $8 billion. We have 4 pillars that we've defined for that. Let me start with the vision. The vision for the bid is that we're going to create a managed care system that maximizes the health status of beneficiaries through evidence and value-based care delivery models. We took stakeholder feedback. We had a little bit of an issue with how we're going to treat pharmacy. We are going regional with it, which we think it's very important to begin to align things regionally so that the same partners, the same leaders are talking about the same individual. I mean, if we're completely fragmented in our contracts, it's going to be more difficult to people to attain our services. But really, it's really built on these pillars of transformation, and this is really going to take a health information technology, health information exchange effort to make these happen. Population health management. So we're going to focus on health outcomes across the total population and within specific target populations as well. Value-focused payment. One of the things that we really need to see, and this is very easy to say from a health policy sort of wonk perspective. We're going to pay for value rather than volume, right? Which makes sense. We're going to pay for quality, not quantity. Well, if you take a step back and really try to figure out how you're going to implement that, as you can imagine, there's a lot of underlying changes that need to occur, both from a policy perspective and from an information sharing perspective. The easiest thing to think about is, the specialists who you go and see reordering an MRI that you had. Well, that's just one example of where we're paying for quantity over quality. And if we can share that MRI electronically, right? If we can, and we've come a long ways from where we were, but we need to make significant improvements there as well. Integration of care continues to be a huge priority. Integration of care now is a subset of what we're doing with the River of Opportunity. Integration of care means how do we make behavioral health and physical health work together? What are we doing to bring together providers in those areas to ensure that they're seeing the entire person, both from a mental health perspective and a physical health perspective? How are we moving towards person-centered care models? How are we integrating population health, proven population health models and behaviors into the physical health care model? What are we doing to encourage primary care physicians to look at prevention? This is built into much of what they do, but you have a system today where many times that's not how they are paid. They're not paid to prevent the sickness, they're paid to treat the sickness. So what can we do to really structurally transform our payment model? And last, we certainly have a HIT component to what we're doing within the Medicaid rebate as well. So you start to see what we're doing at the Department of Health and Human Services, try to use our policy levers in a way to encourage the use of health information exchange. The next thing we have that we're working on that's quite important is our SIM grant, our State Innovation Model Grant. We were one of a few awardees statewide that applied for these grants and was awarded one. We originally received a design grant, and now we're in an implementation phase. It's about really these grants are intended to be transformative in nature, and the governor's embraced this goal. It's one of his policies. When he came into office, it was number 9 on his card. Was reinventing the healthcare system, and this is really a mechanism that we're hoping and expecting will help achieve this goal. The purpose of the blueprint, our title for it is called the Blueprint for Health, the Michigan Blueprint for Health, and it's to test innovation on a small scale to see what works in Michigan. And we are right now working with regions throughout the state to determine who the first few grant recipients will be in this. And there'll also be a round 2 and a round 3. But what we're looking for is where there's strong cooperation in the community with the Medicaid HMOs and with the providers. What can they do? What could they want? What do they think can be successful to develop a model that will increase the efficiency of the healthcare system and eventually lower costs? Key goals for this include strengthening the primary care infrastructure, providing coordinated care to promote positive health and healthcare outcomes, building capacity within communities to improve population health, so you can see the same sorts of themes come into play over and over again, improving the system of care to ensure delivery of care, the right care by the right provider at the right time and at the right place, design system improvements to reduce administrative complexity, and design system improvements that keep insurance premiums affordable for individuals and employers. And they build on some things where we've been successful. Michigan's patient-centered medical home model, we're building upon the MiPIC program, which is really about it's Michigan Primary Care Transformation Grant. This is where some providers and insurers got together and said, what can we do to build in a bonus payment, basically, to the primary care providers to encourage them to begin looking at preventing illness rather than just treating illnesses. The accountable systems of care, building on existing health systems and provider networks and safety net institutions to say, if you come together and potentially reduce the cost of serving this population, what can we do to help share in the savings? Or vice versa, what are you going to do to absorb the greater costs? So that's the whole point of being accountable. Community health innovation regions. This is, again, building on existing community health coalitions and councils at the local level. We're going to look at the payment systems, and then health information and process improvement infrastructure. All this has to be supported through health information technology and exchange statewide efforts and initiatives. In closing, I think I do want to go back to Tim's introduction to me, because I get to serve in a very unique place. We all get certain opportunities in our lifetime, and I'm very fortunate that I was in the right place at the right time in much of this. Much of the opportunity that I've been given to take this on comes about because of the successful implementation of the Healthy Michigan Plan, because of my belief that if you align technology and design it properly, you can really make things better for the customer and for the taxpayer and for, in our case, the people who are paying insurance rates. So again, back to the individual. And it was through this idea that him and I became aligned in many sort of ways, where he became comfortable with me being the department director first for community health and then for both agencies. But I go back, actually, and Tim will remember this, and I don't know if it was at this event 3 years ago? I'd just been appointed chief deputy, and with that, volunteered to be on the Health Information Technology Commission. But we were having one of these types of events, and our director backed out of speaking, and then we had a legislative liaison at the time who then chose to take a different job. So we were scrambling 3 or 4 days trying to find a speaker, and they threw me up here. And I knew so little about this that I told Tim Pletcher, I'll do it, but you have to take half my time. And you can see today, now I can fill it up like crazy. I could talk for another half hour on this. So thanks to Tim for helping bail me out that day. But I think it's the time, people ask, how are you taking this on? 45% of the state budget, $24 billion, 14,000 people. And, at first it was, the attitude in my own head was, well, if not me, then who, right? Which is sort of a defensive posture, if you think about it. And then as you adapt and you get through the first pieces of it, you establish a leadership team and you become confident in what you're doing, and you learn where the budget battles are, you learn what the policy concerns are of the subcommittee chairs, and you go through the negotiations, and you have a few bills that come out, and as you learn the issues, you become more comfortable. But it's pretty interesting, even in my own mind, I've seen a shift in, how is this going to work out, to how am I going to, take this opportunity to make things better for the future. When I talked to the governor about this, we talked about some of the issues that we may face in the near future. The multitudes of state agencies, federal agencies I have to deal with, 150 different federal funding sources, all with different requirements, even different definitions for income, all these things that we have to deal with on a daily basis. How do we align and coordinate these things? And I said, this is a very tough task. And he said, and this is something I think that we all should really think about. His advice to me was, you're setting the framework for the future. You're setting the framework for the future, and it's not about what this looks like 4 months from now, 12 months from now, even potentially 36 months from now. But I want you to take a look back, say 20 years after you leave state government. I want you to take a look back and see how the system works. And I want you to know that you made a difference. And I'm asking each and every one of you to do the same thing today. What the field that you're in is going to drive the success of the people who are trying to do what I'm doing. Without good information, our processes will be broken. Without improved data, without a better concept of what analytics are about, we'll never get beyond process, and we'll never get to the analytical piece of what we can really accomplish with the information that's there. We have to do this in a safe and secure way, and I think from my lessons, from what I've learned from the new 11,000 people that I've taken on, a couple of words of caution. The technology has to work, right? I've seen, as I've talked to people locally, they list their three biggest concerns, and they're always the same. MySACWIS, which is a computer system for child welfare, caseloads, which is their own work they have to do every day, and Bridges, which is the eligibility system that they use. 2 out of the 3 of their biggest issues are technology related. And we can lose credibility quickly if those systems aren't working the way they're supposed to work. Second sort of word of caution, we're in a changing landscape when it comes to healthcare. Burrell versus King is this lawsuit. How many people here know what Burrell versus King is? So basically, there's plaintiffs that sued the federal government saying that the subsidies that are available to make healthcare more affordable under the ACA, you were not eligible for that if you lived in a state that did not design a state-based exchange. We did not design a state-based exchange. We couldn't get legislative approval, so we are a federal partnership state. What this lawsuit, what the plaintiffs are contending is that those states that are like us, that did not create a state-based exchange, individuals in those states who are getting tax credits and subsidies to purchase health insurance will no longer be eligible to receive those. And that will be a very interesting decision going forward. If they find for the plaintiffs on that, it's going to disrupt, my new favorite term, it's going to disrupt the healthcare system in this state and many other states. Definitely going to see some changes at the federal level 2 years down the road. There's already, coming out of this Burrell versus King discussion, I think there's an acceleration of potential conversations around the repeal and replacing Obamacare, right? And certainly we're going to have to react and adapt to all that's there. The federal government made a lot of money available to the states and to all of us to build the backbone, to build the electronic health records initiatives, to build electronic medical record systems. They continue to do so, but we have to pretty quickly prove our success. And I think with the changing landscape, I know that 2 years from today when I wake up, it's going to be a much different world than where we woke up this morning. So I'm imploring you to drive quickly for success, to keep us moving in the right direction, to focus on what the consumer needs both from utilizing the healthcare system, but both also in privacy and preferences, which will be very important, usability be very important, and also focus on what the workers who will be using the system will need, whether that's a doctor, whether it's a health and human services caseworker, whether it's a hospital technician, whether it's a pharmacist, whether it's me sitting in an office trying to figure out what the latest hot spot is for some sort of illness that I can jump in front of and do something about. How can we have usable systems that work? We rely upon you. We rely upon the IT experts to get this done for us. So certainly I applaud you for the work you do and implore you to keep driving forward in a huge way. I talked about what it was like in the late 1980s when I first came into state government. And I can also tell you that compared to 5 years ago, leadership of people like Tim Pletcher and MiHIN, the Michigan Hospital Association, the people who have served on the Health Information Technology Commission, Larry Wagenknecht is here in the room, for example. These people have moved the ball forward in an immense way. We can't lose the momentum. We can do better, and we're going to do better.